for you in one nice image. Curved planar reconstructions are very helpful for looking at individual small vessels, and certainly as thoracic surgeons, knowing the relationship of a central mass to either native coronary arteries or a bypass graft can be helpful. And again, this will just let you view the entire course of, in this case, a coronary artery. Maximal intensity projections, which basically you tell the computer you just want to see the highest intensity voxels, and that's going to make all of your vessels pop, and it's very good for looking at things like small arteriovenous malformations. And then minimal intensity projection is just the opposite. The radiologist tells the computer they just want to see the lowest density voxels, and that highlights things such as the airway, and as we'll see in this case, where the emphysema is quite hard to see on the regular image, these low-density areas of emphysema really pop out. So it can be a way of enhancing detection of mild to moderate emphysema. 3D volume rendering is a very important tool, and I think one that would be helpful, particularly to thoracic surgeons, when you're looking at large structures and trying to get a big picture display of, in this case, how this mediastinal mass, which is in green, relates to other structures such as the airway, which we have here in blue, the aorta and great vessels that we have in yellow, and these venous structures that we have highlighted in red. So, and again, I'm showing you a static image, but the nice thing about a workstation is you can interact with this and look at it in multiple different projections. This is an example just of the type of detail we can now get. This was done with an EKG-gated study, but of the type of detail we can get of structures such as the heart and great vessels. And just to give you a comparison, these are the routine multiplanar images that can be done on any CT console, don't require a workstation. You can get a nice demonstration of this aorta and the pseudoaneurysm, but you'll see with the 3D image you get more of a sense of depth perception, which is absent on the 2D image. We can do both external and internal rendering of structures. This is an example of a high-grade subglottic stenosis, which was overlooked completely on the axial CT images. And just keep in mind that when you're looking at multiple axial images, sometimes you'll only catch that stenosis on one image, or it can't even be in between the images. And this is just an example on the virtual bronchoscopic image. Now, to date, the external rendering has been much more helpful than the virtual imaging, but certainly for things like superdimension guidance, virtual bronchoscopy is having a little bit of a renaissance or reemergence. Practical applications I'll go through now, trying to give you a sense of how these different types of CT techniques can be helpful to you as thoracic surgeons. One certainly an important topic would be lung cancer. And certainly we can improve localization of nodules with respect to their segmental location, their fissural relationships for when you're doing VATS procedures. We can help in terms of deciding resectability of central tumors. And a recent study from European Journal of Cardiothoracic Surgery looked at the ability of CT to determine the pulmonary artery branching pattern before a VATS lobectomy, and found a 95% accuracy, and really just a difficulty for the very small, less than 2 millimeter vessels. This is an example of obvious lung cancer here at the right apex. Very spiculated. We see the fissure nicely on the left, but it's very hard to determine what exactly is the relationship of this tumor to the fissure. And very quickly with the sagittal reformation image, we can see that it's actually straddling the fissure and invading the adjacent superior segment of the left lower lobe. Was not obvious on the axial image at all. For endobronchial lesions, we can very easily give you the distance of the lesion to the carina for staging purposes. A little bit difficult on these oblique airways, such as the main bronchi on axial images, but very easy to do that on a multiplanar reformation and give you a precise measurement of the lesion. As I mentioned earlier, determining the relationship of lung or mediastinal lesions to important vascular structures can be done easily. This is an example of a patient's saphenous vein graft, and you can see the relationship to this large central lung cancer. Now, MRI is a preferred method for preoperative evaluation of superior sulcus lesions, particularly because of its superb ability to look at the brachial plexus. But you may have patients with pacemakers or other contraindications to MRI. And just keep in mind that although it's not as good as MRI, these reformation images can give you some important preoperative planning with regard to the superior sulcus lesions. I'm not going to talk much about it, but these images can also be used for simulation training. A recent study showing that in trainees, improved accuracy of predicting resectability and decreased planning time for surgical procedures using 3D CT. Emphysema, we haven't heard much about that at this particular meeting, but certainly if we're looking for lung volume reduction surgery candidates, we want to know the severity of the emphysema, we want to know the distribution. These coronal reformation images are very easy to demonstrate. For example, in this patient with alpha-1 antitrypsin, the basilar distribution of emphysema. We can also use histograms from CT using a threshold to give you an idea of what the percentage of severity of emphysema is in the upper, mid, and lower lungs. The other thing for the newer endobronchial procedures for lung reduction, keep in mind that the presence or absence of a complete fissure is a helpful determination for whether someone's going to likely benefit from those techniques. And these multiplanar CT images can really help to delineate the incomplete fissures with a high degree of accuracy. Pulmonary vascular disorders certainly can help to identify things like pulmonary AVMs, which we see in this image, and nicely demonstrating your feeding and draining vessels. For the airway, I've shown you some examples of neoplasm already. This is an example of not a 3D technique, but a cine technique of a patient during a coughing procedure. So we can image patients during physiologic maneuvers to look for that. In this case, a patient during repeated coughing showing excessive collapse of both the carina and main bronchi. For tracheal neoplasms, an image like this can very easily show you that this lesion is completely intraluminal, its relationship to the carina and other structures. This proved to represent a benign neurofibroma. For patients requiring airway stents, one size does not fit all. This was a person who'd had prior surgery and radiation with a large trachea, very small carina, and small main bronchi, and the coronal CT could be used to make custom stenting device that would be ideal for this particular individual. One can evaluate any type of stent with CT. We heard a lot about esophageal stenting today. Certainly aortic stent grafts can be assessed. One of the areas where stents have had a lot of complications, although they do provide a lot of palliative improvement, is in the airways. And we've recently shown a 97% accuracy in our group for looking at various complications, including migration, malposition, granulation tissue, and fracture. This is just a typical example of granulation tissue developing within a stent in the left main bronchus. I mentioned virtual imaging a few moments ago, and I think, as I mentioned, that certainly guidance of procedures using things like superdimension is probably the primary role right now of virtual bronchoscopy. Just giving you a sense of the type of correlation we can get. This is a virtual image on your left showing a localized tracheal perforation and correlating beautifully with the conventional image on your right. What about mediastinal masses? Well, again, similar to central lung cancers, you're going to want to know the relationship of the mass to critical vascular structures and also to determine the craniocaudate extent of disease. This is a patient with an aggressive thymic neoplasm, and certainly you get an idea of its extent on the axial image, but very quickly with the coronal and sagittal, you have a nice display of the overall craniocaudate extent of the lesion and its relationship to major structures. Aortic diseases, as I mentioned, these sagittal oblique images, a single image will lay out the entire aorta for you. It can tell you the presence of aneurysm, dissection, or rupture. As I mentioned earlier, we do a very nice job also with the stent grafts and can evaluate those for complications as well. Diffuse lung disease, we heard a lot about the